Our next two speakers will focus on the importance of health literacy and health insurance literacy, once again in the area of health insurance reform. So after the very vigorous discussions we had this morning, Catina, this is going to be up to you. Our first speaker is Dr. Catina O'Leary, who is President and CEO of Health Literacy Missouri. She will talk about what health literacy and health insurance literacy can contribute to really solving the challenges and addressing the issues faced in the health reform marketplace, enrollment, and also the use of health insurance. Dr. O'Leary will be followed by Dr. Judy Hibbard. Judy is a professor of health policy at the University of Oregon. Dr. Hibbard will present a continuum of solutions with examples for the issues we are discussing about health insurance reform. Judy and I go back a little while where we were doing the same kind of thing with a variety of the payers. Again, more information on both speakers can be found in the handouts, and please hold your questions. It'll be helpful if you do that until after both speakers have given their presentations. Catina, all yours.
Good morning, everybody. So this session, titled What Can Health Literacy and Health Insurance Literacy Contribute to Solving the Challenges? I want to say that the Planning Committee really came to this session after a lot of vigorous discussion about how we talk about definitions here, and is there a difference between health literacy and health insurance literacy, and what does that mean and what do we say? And we came to the agreement that there's no reason to stand in front of this group and talk about those definitions and have that conversation, so I'm going to get to spare you that. But I want you to think about this as an application of health literacy to health insurance literacy. And so I'm going to use Missouri as an example of how we've made that application and what we've done. So again, talking about the overlap between health literacy and health insurance literacy is the point this morning for me. And this really gets into the kind of three big tasks that we're asking people to do. So we heard a little bit of this from the panelists earlier this morning. What are the most important components of what we ask people to do? There are a lot of pieces of each of these, but if we put these in big buckets for the folks who have to do the task and get the insurance, it's about getting, keeping, and using. And each of those have their own sets of skills, and each are very complex. So to get, we need to find and evaluate information about health plans. We heard someone say that there were 95 plans to choose from in New York, for example, this time. So really figuring out what those are and figuring out the differences and making choices that make sense for you. And by the way, sometimes the choice is that none of these work for me, and it's a really good choice to maybe not make that selection and use the systems in your community, particularly in a state like Missouri that hasn't expanded. So some of the very few choices we have are not affordable, and we have to think about what that means for folks who are using health insurance and are forced with that choice of using very limited funds to pay for something that they may or may not use, and the choices between that and eating. So finding and evaluating that information and making good choices, choosing the best plan for their situation. Of course, then we want them to keep it with paying their premiums, renewing, re-enrolling, various levels of tasks that are involved with that, depending on who you are and where you are. And then using it, which is the really big kind of hurdle for folks. We talked this morning just a little bit about how this is a kind of a learned skill and people have to do it. But for a lot of people, getting those first appointments under their belt takes a long time because they have to find the doctor and use the insurance and do all of that stuff. So it's a big job we're asking folks to do. But these are all associated with health literacy basic skills, and we have strategies that we apply in other parts of health that can be used to help people here. So again, I want to use Missouri as an example, and I'm going to talk about our work with the Cover Missouri Coalition. So this is a project of the Missouri Foundation for Health in a non-expansion state. So what we figured out is we weren't going to be able to make much progress in Missouri unless someone got involved, and for us it was a funder. The Missouri Foundation for Health has a good amount of resource, and they're able to pick big ticket items and really focus attention. They had three goals: to promote quality, affordable health coverage for every Missourian. We wanted to lower the rate of uninsured Missourians to 5% by 2018. I was really jealous to hear that New York had done that. We think we'd be closer, except for the fact that we have an expanded Medicaid, so we've got a whole bunch of folks in the gap that we can't really help right now. And we want to improve the health insurance literacy of Missourians. So we did that really with a partnership approach. I was excited to hear someone say early on that coalitions matter, relationships matter, partnerships matter. We really found that to be true in Missouri. So this graphic shows what our partnership looked like. So we had the regional hubs in the big circle. These were folks all around the state of Missouri that were really on the ground, that worked closely together to bring the issues from the ground up to the foundation and to talk about those things with us. The foundation also funded grantees, so folks got navigator funds from the Missouri Foundation for Health in addition to whatever else the government offered. So people were able to get funds for navigators and assisters through that program. And there are a whole bunch of partner agencies, about 900 of them overall, so a pretty robust coalition that served the whole state. And then along the side, you'll see the bubbles for the coalition support, and this is where we fall in. So the top blue bubble is a company called Stratcom RX, and that company worked to organize the 900 organized community groups to really keep the facilitators involved, keep the funders connected with us. We meet regularly, so the coalition meets every month, but also the working groups and the technical assistants and all of us folks meet every month, and there are weekly calls, and there's a lot of activity. There's an awareness and communication group, so Fleischman Hillard is a big company that does part of that work. There's also a group called Missouri Healthcare for All. That's a small nonprofit in Missouri that really is advocacy and organizing focused. Us at Health Literacy Missouri, we did the health insurance literacy work. So we were very specifically funded to work with the navigators and assisters to help them learn health literacy. But also think about how the things that they're doing in community needed support, and I'll talk a lot about that as we go along. Community Catalyst talks about technical assistance, and Dara Taylor is here. She's going to talk a little bit later about her work, so I'm not going to say any more right now. And then we have an evaluation partner at Washington University in St. Louis, and they really kept us on track as we went along the way and helped us think about what's next and where we are and how to continue working toward our goals. So our role, we provide support. We did work to develop clear resources to help people understand their insurance. We wanted to improve assisters' interactions with consumers, and we wanted to provide support and training to assisters. So those were the things that we were initially funded to do. As we talk more, you'll see that our work really was much larger and different than that over time, and it was because we applied these basic health literacy strategies that we all know and love over and over again. So the work kind of grew into a much bigger collaborative process. So one of the things we know, though, is successful strategies to address this work rely on relationships among diverse stakeholders. So the 900 partners we had there, all of the folks we were working with, everybody we heard this morning talked about the people who were connected together and how they connected to community. So it's not always that I'm connected to community, but somebody has to be connected to community. And that audience interaction, who's the person that needs the service and how do we talk to them, is really critical in this work. But there are stakeholders beyond the folks who are actually enrolling in insurance. And for us, there are at least 6 key stakeholders. So they're the patients and consumers. Obviously, they're the folks who need to be insured. But the insurers are a stakeholder here. They have a lot of information. They have a key kind of driving force around what happens and how it happens and what things cost. And it's important that they're involved in the conversation. Government folks have structured this Affordable Care Plan, so they show up. The hospitals, again, in a non-Medicaid expansion state, how the hospitals partner and what that means is a critical issue, and where they show up and how we engage matters. The community organizations who are assisters, but they're also the folks that are seeing people when they first start to use their health insurance. The community organizations are the places that folks were going before when they were uninsured, and they often still want to go back to those spots when they get insured. And so figuring out what those relationships look like and how they keep supporting them is important. And then we work with the assisters and the Health Insurance Literacy Working Group to keep issues moving forward. So just to orient, in Missouri, we had 877,000 uninsured folks when we started in 2012, and we've done a decent job enrolling. We're really proud of our work, particularly, again, we're in a non-expansion state where people are really angry about health insurance. They're angry to have to get it. When you talk about health insurance, they talk about Obamacare, and it's really a negative phrase, and it's a negative attitude, and everybody who's left uninsured in Missouri absolutely knows they're supposed to be insured. They absolutely know somebody who's talked to them about it. These folks aren't hiding out and have been unreached. These are people who are actively making the decision that they either don't want to now, or maybe they don't want to ever, or they don't understand. But it's not this lack of awareness for us. It's really an active conversation and a conversion of kind of thinking and philosophy and behavior over time. By year 3, though, we had enrolled 290,000 folks, and we were about 9th in the nation, and we're pretty proud of that. So again, how do we apply our health literacy strategies? So one of the things we did early and often is we used a Cover Missouri Health Insurance Working Group folks to really point us toward topics that were important. So these are folks that are assisters on the ground. They're talking to people every day, and they were able to tell us what topics were difficult to explain to consumers, and consumers had trouble understanding, and they asked for creation of those materials. So working with our partners at Community Catalyst and Fleischman and other places, we were able to address the issues factually. We were able to make sure that we had the correct policy information, but then design something that worked. And we would take it back to the working group, and we would say, is this what you meant? Does this work? Do you understand it? Explain to us what you see. And then they took it out to their audience and kind of did the same thing. And so we used that rolling process to make sure that we walked away with materials that structured conversations and also really supported follow-up and conversations with family over time. So what we know from these folks in these groups is many times, because there are so many plans, they wanted things like worksheets and checklists and things they could pick up and use together with consumers. And so we helped create those. We also made them pretty and branded them and applied all the best strategies in health literacy so that when you saw it, it felt like it was something. Because we really want to transmit also that feel good, that this is a thing you want and this is a thing that's good and feels good. We asked them to test materials, answer questions about usability. We also use these groups for focus groups. So we went out into Missouri and we talked to newly insured and uninsured folks to talk about gaps in their knowledge. We wanted to know about how they like to get health information, and we also wanted them to talk to us about our materials. So we went straight to the source at times. They told us things like, we heard earlier this morning, they really want simple materials and information about health insurance, but that's not enough. So this is where they got to over and over again, the direct in-person connection with someone that they know and trust, someone from their community is critical. They have quotes like this that you can read, but I just want to do better in life no matter what I'm doing. If somebody can explain it to me, if I have to read it, it's going to take me like 27,000 times to grasp it. That's a literacy issue, right? That's an understanding issue. And it's also just a confidence. And these sisters were really able to transfer a confidence and competence to them and train them over time. And so they really still talk about wanting and needing that in-person health. They want somebody who's knowledgeable about what's out there, somebody to lead the way. They also talked a lot about materials and consumer preferences, and so there's a lot of data about this. These are just 4 examples of what we asked. The simple words matter. They really liked healthcare.gov instead of marketplace. Again, I think we've talked about that before over and over again, but just another group of people. Doctor instead of provider. They talked a lot about this. Every person that comes in the room they assume is a doctor or a representative of the doctor. They don't care about the derivations of, this is the nurse and this is the receptionist. They just want to know that the person comes there with the correct information and it's speaking for the provider that you asked to help you. They like fee instead of penalty or shared responsibility. It's just the easy word. Financial help makes more sense than credits to the best of their ability. And sometimes there are restrictions. We hear that from the insurance providers, is particularly when the state gets involved, there are requirements about what words they use. But we know from health literacy that we have to use those words, but we can also use the other words too. So there are workarounds that we apply in medical care all the time that we're not applying here systematically. And so I think we need to think about that. So strategies to help the consumers. So we had lots of print materials. So for us, we had to talk a lot. The assisters talked to us about things like MAGI, the modified adjusted gross income. This was really hard for them to talk about. Didn't matter how much training they had. They found it really hard to do it over and over again, and they wanted something to structure the conversation. So you can see that we created a worksheet with them, that we put the steps in place, we explained the words, and then we helped them with the amounts in every step of the way so they didn't have to remember it, because there's no good reason they have to remember it. This is not a test, right? This is a relationship, this is an activity, and we want to get to a goal of understanding together what we're supposed to do. So things like this really made a difference for them. And you'll see that we, used health literacy best practices, step 1, step 2, we totaled those up, we put the plus signs and equals, but we really worked them through the progress so that they could figure out how to do this and make tax information more easy and more clear. Medicaid gap was also a big problem for us. It wasn't that the Medicaid gap was hard to understand in Missouri. Everybody kind of got the concept of the gap. But for the assisters and navigators, it was painful to have to tell somebody they were in the gap. And it was hard to generate that conversation over and over again that nothing works for you. All these other people are getting a benefit, but I'm sorry, today nothing works for you and you're not qualified. And maybe if you come back, if your situation changes. They didn't like that for good reason. I wouldn't like it either. But they asked us for material to help them through that conversation so that they could point in another direction and really structure that. So we created a graphic with information, and we tested this with the folks in the community, but this idea that there are folks who qualify for Medicaid, there are folks who can go to the marketplace, and then there's this gap in the middle, and this is where you are. And we had the incomes in the middle so that we could show people very clearly if your income changes a little bit one way or the other, perhaps you'll be in a different part of the grid. But for now, you're in this spot that's a pretty terrible spot. And then they spent the time with empathy and other resources to say, yes, this is really bad, and let's talk about what else you can do. Let's talk about the FQHCs that offer free services in your community. So one of the things that our coalition did is help them think about what those conversations looked like after you said, no, I'm sorry. We did training videos, getting to the question that was asked earlier. So we had 10 videos to help professionals explain insurance topics like preventive care, explanation of benefits, appeals. We also started with just basic health literacy as well. So we talked to people about what health literacy was and what strategies they could use, verbal and written communications. These are all available on YouTube, takeable, usable. People can sign up and use the videos. There are also e-learnings. So in addition to online and in-person trainings and virtual office hours, we had these 8 e-learnings that were the same kind of materials. People can go on and work through the project, learn 8 sets of things. We found that folks had a hard time doing this, particularly during the open enrollment periods. But if we could situate the e-learnings before open enrollment period or even right after, it really helped people direct activities when things were ramping up or cooling down. So now is a really good time for training, we keep hearing. So we keep reminding people that these are there and available. And the other thing we did, though, is online trainings, webinar form every month. We also go out into the communities with our partners quarterly, basically, to all the regional hubs. And we have a list of trainings that are offered, and we ask people what do they need in their in their region. And we do those live and in person, and they're tailored. So part of what we do is we don't just take a shelf talk and present it in the Southeast Missouri hub. We take a talk about a topic in health literacy, and then we tailor it for that community. And then we often train them how to give that same talk so that they can go out and do the work in their community without us. And so it's really kind of building that sustainability for them, with them as we go along. There are also a good amount of strategies for consumers. So people needed to know information like what you need to enroll in the marketplace. So they wanted to take away information from the assisters so that they could go home and know what they were supposed to fill in. So we heard information this morning about, what have they got to remember, what have they got to bring, all of this stuff. We have worksheets to support that. But also more basic, what's the process even look like? You can hear that from a sister and walk through it, certainly, but if you can walk through it with something to look at and then take that away with you, consumers have told us that's really helpful. We did a health insurance video series. So these were for assisters and navigators. So sometimes people don't want to go through an hour-long e-learning, but they want to learn in another way. So we did 10 videos, 6 in English and 4 in Spanish, and they were to help consumers to understand health insurance in the marketplace. But the assisters also really were into these. They used these to support their own learning and materials, and then they were able to show them to consumers. So what we heard that they did is when they were starting to have that pre-enrollment talk and the office was really full, they'd set up an iPad or they'd set it up on a computer screen and they would just play it so that people were prepared when it was time to start the conversation. So those are still all out there as well. So things like choosing marketplace, words to know, all kinds of things that we've already talked about in the other group. We did social media work, so tips on how to get the most out of health insurance and health care. And we also do work with the Family Support Division of the state of Missouri. So getting away from choosing a plan, there are a lot of folks in a lot of states that have other benefits that are not directly associated with the Affordable Care Act, but they're covering their health and their well-being. So there's a lot of work that's going on with that I just don't want to get away from. That support is really important, particularly for folks that are in the Medicaid gap. So if you can't get health care, getting coverage to support your food or other things maybe means that your limited funds can be used to support a health plan or copay at a FQHC or other things. But we found in Missouri, like in other places, that the forms and materials people are asked to use and understand are pretty horrific. So we are working with the Missouri Department of Social Services on the food stamps program and other things to help make these forms, materials, letters, all of these pieces of information more readable and usable. We We have a partnership with the state of Oklahoma, getting away from Missouri, just to say these things are really transferable. So we do technical assistance to increase health insurance literacy and health literacy for state of Oklahoma employees. So getting back to the idea that this isn't just people on the street who have never been insured. There are 38,000 employees in the state of Oklahoma system, government system, and they tell us it's really hard for them to understand how to pick a plan. They were given a lot of options of how to pick a plan, and a lot of people selected plans at a lower level, even though it would have been covered to pick a higher level plan, and they found that the plan they selected didn't work for them, and they had lots of costs that were unanticipated. It was pretty traumatic for a lot of the employees, and so we're working to help the state figure out how to help their employees figure this out. I think that's a statement when we talk about kind of who needs what. These are folks that we think know, and I think that's a testament to how hard this stuff is, and how clear we want to be, and really how accessible everything needs to be as we go forward. So we're training benefits coordinators, we're doing social media work and webinars for all the employees who are in the state. So hopefully we'll be able to help those folks and move that forward. But I want to talk just a minute about the next step, because this is, I think, really the most important thing. When we talk about who's left, getting to those folks that are left is really a big challenge, because they've had lots of opportunity. Many of them are people who really are resource deprived, and we're asking them to do something that is very, very hard, and it's a different choice, and maybe not the smartest choice always for what they need to do. So what we've decided to do through the Cover Missouri group is we're going to do a deep, engaged community strategy in 4 under-resourced communities across Missouri. So we're going to go to these 4 communities, and we're going to do things like go back to media partnerships. So talk to the local newspapers, talk to the radio stations, talk to the people, partner with the schools, partner with local health departments, partner with all the folks in the hospital systems, go to all the fairs, every single thing that those people do. But it's not about, here we are, we're Cover Missouri, we're going to help you. It's this idea of, okay, so health challenges, how do we talk about what's important to you, what's responsive to a community need, so they can tell us what they need. And it may not first be health insurance. So we'll start with wellness and health and care, and we'll move toward health insurance when that comes up from communities. We don't know how quickly we'll get there, but we're pretty excited about that. So it's print, media, it's partnership, it's person-centered, kind of this deep connected relationship with these folks. The interesting thing about this, though, is because the Missouri Foundation for Health covers this, it means we have to cover their whole service area, essentially. So that means we're going to be going to 4 corners of the state, and these are the 4 corners of the state that are the hardest to reach. Right, so we'll have somebody in the middle that's kind of easy to reach, but everybody else is kind of out there on the edges. And so we're going to get to see what that's like to be in these rural communities and figure out what it means to apply these strategies with folks that are really hard to reach. And, I hate to use the word hard to engage, because that implies it's their problem, but this idea of our engagement strategies haven't reached them yet. So how do we figure out how to do the work we need to do with them so we can move them toward health and wellness? So we'll try to reach and engage the remaining uninsured around health and health coverage. We're going to support existing health and wellness and enrollment activities in the community. So this is not creating new, this is layering and supporting what's there, and how to have relationships. Again, this idea of relationships, partnerships, coalitions, I think is so critical to the work that we're doing. And we want to make the connection between health and health insurance, because you never know when you're going to have your arm broken or whatever a sudden health condition is, and that's going to change all of your plans. But you need to be prepared for that, and health insurance is one way that you can prepare. So I think I'm finished. Thank you very much.